Hi guys, this is a short lecture to finish up the heart. This is the last of the material that's on your third exam. I put an announcement up about your third exam that hopefully will answer any questions that you have. Other questions, please post in the discussion so that people will benefit from seeing that question and answer. Okay, so we are almost finished with the heart. I just kind of ran out of steam. I don't know about any of you guys, but this is a little exhausting, probably for all of us. So the last thing that we have to cover is just what we call the conducting system or the cardiac conduction system and innervation of the heart. Let me make sure that that video is messed up. Hold on just a second. Of course. I always forget that those get screwed up when I plug in the monitor. So wait right there. Okay. So the conducting system of the heart. So you guys are doing heart this week and vessels next week, I think, if that's right. Okay, so couple things I want to tell you. First off, if you look at the actual myocardium, the actual cardiac muscle cells, there is a small percentage of those, and it's represented in yellow here, which makes everybody think that it's nervous tissue, but it's not nervous tissue. There's a small percentage of cardiac muscle cells that don't contract. They're specialized instead to send out a stimulus that will start a contraction in their neighbors on a rhythmic basis. These cells are called conducting cells or pacemaker cells, and they develop embryonically. So they just lose their ability to contract, and instead they're specialized in transmitting impulses, action potentials that cause other cells to contract. A compact mass of those is called a node. And so the two nodes that you are learning are these two guys right here. This one is called the Sinoatrial Node. The Sinoatrial Node is really the boss. It is actually the pacemaker of a healthy heart. And it is going to initiate each cardiac cycle. And a cardiac cycle is really the combination of send out an electrical signal, atria contract, pause, and then ventricles contract, okay? And the opening and closing of the valves that's involved in that. So the SA node right here is the real pacemaker of the heart. It's located in the wall of the right atrium. It's just inferior to the opening of the superior vena cava. If you were looking at an actual specimen, which would be fantastic right now, wouldn't it? If you were looking at an actual specimen, you wouldn't really be able to see it because it's just cells that are specialized within the wall of the actual myocardium. And so what this SA node does is it actually sends out a stimulus through the gap junctions that are actually connecting the cardiac muscle cells. It sends out a gap junction about 100 times per minute. And so what it does is it spreads through the atria, top to bottom, and then the cells will contract in the order that they get the stimulus. I'll show you an animation in just a second. So it spreads through the atria, top to bottom, and then the atria will contract top to bottom, which is fantastic, of course, because the valves and the ventricles are below the atria. So we want to push the last little bit of blood in from the atrium to the ventricles. Remember that your cardiac muscle cells are connected by these intercalated discs with gap junctions in them. So the way that they're connected allows the stimulus to flow from one cell to the other. So in the inferior part of the interatrial septum right here is the other node. This node right here is called the Atrioventricular Node. The location of the AV node is sort of, here's the interatrial septum. It's right down at the bottom of the interatrial septum. It kind of is a little misleading where that is. And what that atrioventricular node does is it is controlled by the SA node. After the SA node sends the stimulus out and causes the atria to contract top to bottom, it will also flood the AV node, the atrioventricular node, and then it will tell the atrioventricular node that now it's time to start the stimulus that will eventually result in ventricular contraction. But the AV node, what it does is the AV node is still those pacemaker cells. They don't contract. And then this, what you're seeing right here, is called the AV bundle, sometimes also called the bundle of His. There's this guy named His found it. The AV bundle looks like it's a nerve, but it's not. What it is instead of a blob of those pacemaker cells, it's a chain of those pacemaker cells that are actually connected together via gap junctions. So I'm still not talking to the contractile cells yet. And then the bundle branches, left and right bundle branches, get the stimulus next. Again, still these are pacemaker cells, not contractile cells. And what they are going to do is they are going to take the stimulus and divide the stimulus so that it goes into the left and right atria. As the stimulus goes to the left and right atria, we still haven't talked to any contractile cells at all. When I will begin talking to contractile cells is when I get to what's next. And what's next is these little guys right here that you can see. Those are called Purkinje fibers, and the Purkinje fibers actually allow the pacemaker cells to communicate with the contractile cells. So what happens is that the pacemaker cells only talk to each other as they're going all the way down here, as they're going AV node, down the AV bundle, down the left and right bundle branches. They're still only talking to other pacemaker cells. They only start to talk to the contractile cells once they get to the Purkinje fibers. And what's important about that is that means that the atria contract top down, right? And then the AV node gets the stimulus and sends it down, the AV bundle, the left and right bundle branches, and then to the Purkinje fibers. So the ventricles contract bottom and sides up, which is good because, of course, that's where the valves are. This one is only showing one of your semilunar valves just because that's the way they cut it. But you are going to push blood up from the bottom of the ventricle, and it's going to push on the back of the AV valves, bicuspid and tricuspid, and close those. And then as you generate a little bit more pressure, it will push on the semilunar valves, aortic semilunar you're seeing here, and not shown in this picture is the pulmonary semilunar, and it will open those. So what this does is sort of two things. This allows for a lag time between atrial contraction and ventricular contraction. And that lag time is to allow for ventricular filling. And then it also forces the ventricles to contract bottom and sides up. So finally the ventricles will contract about 0.2 of a second after the atria, which is good for ventricular filling. So now let's show that animation, give you guys a visual on this.
Action potential.
Oops, sorry, hold on. I don't know ever if you can hear these very well, but I will do my best.
Action potentials originate in the Sinoatrial Node and travel across the wall of the atrium from the Sinoatrial Node to the Atrioventricular Node. Action potentials pass slowly through the Atrioventricular Node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the Atrioventricular Node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
Okay, so let's turn off the audio on this one and then run through it one more time. Okay, so what we are seeing is SA node depolarizes. It's not showing you contracting yet. And then AV node depolarizes, which gets the stimulus. Sends it down the AV bundle to the left and right bundle branches and then up the Purkinje fibers. Now what they're showing here is that will cause atrial contraction, pause ventricular contraction, atrial contraction, pause ventricular contraction. Hold on, let me just let it go for a second. Okay, atrial contraction, ventricular contraction, atrial contraction, ventricular contraction. So the ventricles lag behind the atria in their contraction. Okay, so the motor innervation of the heart. So what I've told you here is that basically the heart initiates its own contraction, and it does it by these pacemaker cells that just initiate a contraction about 100 times per minute. So what does the nervous system do for the heart if the heart initiates its own contraction? So the heart is definitely innervated by autonomic motor nerves, and we talked about that in the nervous system, right? So the sympathetic nervous system can turn the heart up, and the parasympathetic nervous system can turn the heart down. But here's what the nervous system cannot do to the heart. The nervous system does not initiate a heartbeat or a contraction. It only can increase or decrease the rate of contraction. So this goes back to the gas and brakes metaphor. So do the gas and brakes change anything about the speed your car is going if it isn't started? And of course the answer is no. They don't do anything to speed if your car is not started. So I want you to think of the SA node, our friend here, as the starter of the car, right? Why the hell is it doing that? The SA node starts, and then after the car is started, you can use the sympathetic nervous system to accelerate the heart rate. And what it does, and this is putting it back together with more stuff that we've already learned, is, okay, so you guys learned many times, well, not many times, I hope you learned because it's on the next test, that the medulla oblongata, actually, oops, sorry, I'm a menace today. The medulla oblongata, okay, and that's what this is trying to show you. The medulla oblongata, actually, so I told you the medulla oblongata controls heart rate and vasoconstriction and vasodilation, and you know, sympathetic nervous system and parasympathetic nervous system. So now I'm just going to put this story together really quickly. So this is the medulla oblongata that you're looking at right here, and so let's put this whole story together. So basically what we are going to say is that the medulla oblongata can decide to, for instance, stimulate the sympathetic nervous system. If it did, what you would do is you would say the medulla oblongata decides that you need to increase your heart rate. Maybe there's a tiger in the room, or maybe you're exercising, or maybe there's a pandemic, I don't know. And what it's going to do, if it does that, is it's going to send the stimulus down to the thoracic region of the spinal cord. Then the stimulus is going to go out to the sympathetic chain ganglia, right? And then it's going to go to the cardiac muscle effector organ. And then what it will do is it will increase your heart rate because there's a tiger, okay? So this is putting all three together. Three things that you've learned before are medulla oblongata controls heart rate, sympathetic nervous system increases heart rate, and SA and AV node. So what's going to go on is medulla oblongata says tiger, sends out the stimulus through the thoracic region of the spinal cord because that's where the sympathetic nervous system originates, goes out to a sympathetic ganglion, right? The sympathetic chain ganglia, which are lateral to the spinal cord, and then out to the effector. And where does it primarily impact to increase heart rates? It goes to SA node and AV node. Don't worry about that part because that's a phys thing. Okay, but what if it's not a tiger, or the tiger leaves the room, or the pandemic is finally over? What happens then? What happens then is the medulla oblongata is still in control, only this time it says, I need to decrease the heart rate. And it does that by, instead of stimulating the sympathetic nervous system. It stimulates the parasympathetic nervous system via the vagus nerve, cranial nerve number 10. Again, information all coming together here. And that is going to go out cranial nerve number 10, two of them, right? A pair of cranial nerve number 10s. And what they are going to do is they're going to go to the SA node and the AV node, and they're going to say, put on the brakes to the heart. Slow down. So, synapses with the cardiac muscle at the SA and the AV node. So, I told you that the SA node sort of inherently goes about 100 times per minute, but your resting heart rate, I hope it's not 100 times per minute. So what is generally happening is your medulla oblongata is constantly, almost constantly, telling the parasympathetic nervous system to sort of keep its foot on the brakes, right? So you've always got your foot a little bit on the brakes, and you're slowing the heart rate down to, at rest, about 65 to 75 beats per minute. If you're in super good shape, it's way lower than that. And that's at rest, right? So it's constantly sort of keeping its foot on the brakes. So if you take your foot off the brake, of course, the heart rate will go up, but only up to about 100. But if there was a tiger, that wouldn't be enough. You would have to also increase it above 100 with the sympathetic nervous system. So the question I ask here, the heart contracts about 75 times per minute at rest-ish, despite the fact that the SA node stimulus rate is about 100 times per minute. And I ask you, what does that imply about the autonomic effect on the resting heart rate? Which one, sympathetic or parasympathetic, is generally in control of your resting heart rate? And it's the parasympathetic nervous system. Now, your heart, this is all motor, right? This is all autonomic motor, but your heart is also innervated by visceral sensory fibers. So can your heart hurt? It can, but it's usually referred pain to the left arm when that occurs. Okay, so a little bit about abnormalities of conduction. So do the atria and the ventricles ever become discoordinated from one another? Because this is what they should do. I'm so uncoordinated and it's really difficult to do backwards too. Atrial contraction, pause, ventricular contraction. Atrial contraction, ventricular contraction. Atrial contraction, ventricular contraction. They're supposed to be coordinated with one another. Does it ever happen that they become discoordinated with one another? And the answer is, of course it does, right? So what happens when that occurs, and I'll post a funny little link to a video for it, is that if you have, there are a whole bunch of abnormalities of conduction, and conduction is sending the electrical signal, but an abnormality of conduction can cause an abnormality of contraction, and I'm just going to talk about two of them with you, and then we'll be done with this video, and I'll talk to you about those two things. So what about atrial fibrillation and ventricular fibrillation? So atrial fibrillation would be when your ventricles are doing what they're supposed to be doing. Imagine that I'm coordinated enough to keep this going, but your atria are spazzing out, right? Your ventricles are fine, your atria are spazzing out. That's atrial fibrillation. But ventricular fibrillation is when your atria are doing fine and your ventricles are spazzing out, okay? So which one of those do you think is more immediately life-threatening? Any idea? Atrial fibrillation or ventricular fibrillation? And the answer is ventricular fibrillation, because of course if your ventricles aren't contracting, you're not pushing blood into the systemic and pulmonary circuits. So this is immediately life-threatening. The fibrillating ventricles are useless as pumps. And so this can cause a myocardial infarction, which is the fancy word for a heart attack. Because if I'm not pushing blood into the aorta, then the blood is not going into the right and left coronary arteries, and therefore the heart is not getting blood to its capillaries. It can also cause a stroke because you're not getting enough blood to your brain. So what do you need to do? You need to defibrillate. Ventricular fibrillation, defibrillation. Sorry. You need to administer strong electric shock. Clear. There's also chemicals that do it now, which depolarizes the entire myocardium. And then you just wait. And what are you waiting for? So people a lot of times think that defibrillation is restarting your heart, but it's totally not doing that. It's stopping all of this misbehaving electrical activity and then waiting for the starter to initiate contraction again on its own. And again, remember your starter right there is the SA node. So you have to wait just to see if the SA node picks it up. We don't have a way to restart the SA node. It has to do it on its own. What about atrial fibrillation? When the atria are spazzing out, but the ventricles are still doing okay. You can live with atrial fibrillation because I have atrial fibrillation. And so the ventricles, I told you guys before, a lot of people are in the habit of thinking that atrial contraction is what opens the AV valves, the bicuspid and tricuspid. That's not what opens them. It's just the pressure of the blood returning. So the deal is that the blood will still be going from the atria to the ventricles, even if the atria don't contract. So the ventricles are still going to continue to fill and pump blood. But two things happen. First off, if the atria don't contract, you don't squish that last 20% of blood from the atria to the ventricles. And then second, you don't want blood sitting around. And if it just sits in the atria instead of getting squished, that last 20%, then the stasis of blood that occurs there can induce thrombosis, which is inappropriate clot formation, and may result in an embolism, which is when a clot forms and then gets circulated through the body, which can cause a stroke or a heart attack or a pulmonary embolism. So it is dangerous, especially if you are in AFib for a long period of time. And a lot of times they have to treat you with anticoagulants after a long bout of atrial fibrillation. And from last time I checked with my cardiologist, you're at increased risk of stroke or heart attack for about 2 weeks if you've been in a long bout of atrial fibrillation. Okay, that's it, except for this last little bit. The pictures that I showed you in the last set of notes, I linked right here. There are some labeling activities. I know some of you guys like these. I don't grade them. I'm not going to grade them or anything. But here is the labeling activity that I scanned out of one book, which is cool because it's got the systemic and pulmonary circuits, and it lets you practice with them. And then this one I just made for you. There it is. Basically, just the unlabeled image, and you can label them yourself. I didn't want to put leader lines in because I think you guys can do that. If those are helpful to you, you can send me on the discussion board, first off, a thank you, and then second, a request. And I can either post the blank images and you can make your own labeling pages, or if I have time, I can do the labeling pages in which you just list out everything and then everybody can use them. And by the way, this is just in Google Draw. You can actually label them on this drawing, or you can print them out and label them by hand, whichever you prefer. Okay, so that's it for the material for the third exam. I put up a discussion so you could ask questions about the exam if you want, and as soon as I determine the exact time and everything, I will put that again up as an announcement. Okay, by the way, if anybody's watching this today, this is Friday the 3rd, and you have a discussion that is graded and due today, not because I don't think you have enough to do, but because I need you to keep in contact, or else it's easy for you to fall through the cracks. Okay, I will be talking with you guys soon.